So first, our learning objectives of today will be to discuss the different forms and dynamics of Krabbe's disease, to identify the first symptoms of the disease. That is very important because as you can see at the end, as you will see at the end, treatment options for the moment are very much dependent on identifying patients early. And then to know about the role of neuroimaging and biochemistry and genetics for diagnosis and counseling. And then, of course, to understand the treatment options. So after a short introduction, I'll go into the methods we used and tell you about the natural history and imaging findings, the diagnostic procedures and treatment options. And I would like to start with two children, and would like to ask you to identify what they have, or we discuss with you what they have in common. The first child had a normal development during the first 4 months, and then the child gets more and more irritable, cries often, gets into opisthostonus, and very rapidly then loses capabilities such as grasping and has less visual contact. And when we saw him first, he was markedly irritable and had a tone increase, and there was already evidence for a peripheral neuropathy. Whereas the other child had a normal development into the second decade. And then her gait appeared a bit strange, a bit staggery and clumsy. And on retrospect, parents told us that she had hollow feet already since 4 years. And when looking at her, she had, and doing the examination, she had demyelinating polyneuropathy, and she had clear pyramidal signs. So she had two reasons for having an abnormal gait. And when you ask the question, what do they have in common? The first thing is they had a normal development, because they, in fact, the dynamics is very different, but some things are very common, very similar. First, the normal development. And then on the neurological examination, both had as well signs for a peripheral nervous system affection and a central nervous system affection. And to again show you or pinpoint the fact that these, of course, it's two children with Krabbe's disease, because we're talking about Krabbe's disease. These children usually have an absolutely normal beginning of their development, even the very early forms. And it is a bit dependent on the forms, at what time this normal development stagnates and goes into then regression. Then when we look at the MRI, the first child was seen by us with 6 months, and the MR at the first glimpse, you would think at 6 months, it's not so very abnormal, but because myelination is of course far from complete. But when you look at the fact that it is the central parts which are not myelinated, even in the centrum semiovale, in contrast to the more peripheral part, this is already pathological. And in the other child, at first glimpse, this looked really completely normal. But then when you look in more detail, on the other brain regions, you identified crucial signs for Krabbe's disease. The first child had very typical signal abnormalities in the cerebellar dentate nucleus and the cerebellar white matter. Here and here. And the second child, and here you have really to go into detail, in which was not identified by the first radiologist, had an abnormal signal along the posterior horns. And when you look at the corpus callosum, you can identify that in the front it looks completely black, but here it's clearly, you have really to concentrate on that. It is not normal. The corpus callosum is affected, and these things, the corpus callosum and these peritracheal signal abnormalities, are absolutely suggestive of Krabbe's disease. So to give you an overview now, the Krabbe's disease is a very rare lysosomal storage disorder. The estimated incidence, also new incidences, is about 1 to 300,000 live births. behind Krabbe's disease are mutations in the GALC gene, which lead to a deficiency of the enzyme beta-galactoseroperoxidase, and there are. It's quite well known since quite a long time that there are the most typical form is a very early starting form, the classical infantile form. There is a good description of Hackberg already in 1969. And this is a very early starting and rapidly progressing disease which is associated to early death. And this has been quite extensively described. And I'm just showing you some typical, some major publications. But I have shown you a child with a later onset. This disease course is much less well known and probably under-recognized. Although it has been quite often already discussed in publications and systematic reviews, as you can see on the right side. I would like to present you now data from our study, which we did in Germany, within the concept of the LeukoNet, which was started in 2003, but we continue to collect data beyond the end of LeukoNet, and the data I'm presenting to you are covering a period of collection between 2003 and 2017. We tried to collect developmental milestones, that means the gain and loss of motor function, language and cognition by means of a standardized questionnaire. We also looked at, of course, at the clinical data and the neurological data, and we did the evaluation of the MRI according to a pattern recognition approach, which was suggested by Abdel Halim in 2014, which we thought very proper and very helpful. And altogether, we had 38 patients and 40 MRs of 27 patients. And the first thing is, when does Krabbe's disease usually start? And you can see here the different categories of onset. And I have to tell you from the beginning that this is a classification which we also adopted from Abdel Halim because we thought it is the most often used, but there are other classifications or sub-classifications, but what is in common of all is that they make the differentiation between infantile and so between the onset in the first year and what comes later. And we thus identified children with an onset during the first 6 months versus during the next 6 months. And you can see that they form by far, especially the first group, the majority of patients. 71% were early infantile, and only 8%, another 8% came later in the first year of the life, and whereas later onset, especially adolescent and adult onset was rather rare in our series. So altogether, nearly 80% had an infantile onset. And when you compare that to the literature, especially to, well, there are really collected a lot of data in the Worldwide Register, started in the United States in 1997. They have, in fact, quite a similar setup. Here in 122 patients, they identified 72 versus our 79 with an infantile onset, a bit more than we had in the late onset, late infantile, so around 60% early and 10% late infantile, and 22% between 13 months and 10 years, and then very similar to us, 5% with a very late onset. This is a little bit different from what our colleagues in Heidelberg reanalyzed in published cases. They took all published cases together, and it's probably because later onset patients are considered a bit unusual, so they may be in non-population based or epidemiological approaches that they may be a bit overrepresented. They found more adult cases, but but around 2/3 at least infantile cases also. That means that in the majority of cases, that is the first important feedback to you, in the majority of patients, Krabbe starts during the first year of life, mostly during the first 6 months. And that's why the later onset forms are a little bit under-recognized, because you are so much impressed, so to speak, by the infantile onset. And indeed, this infantile onset is characterized by something which is noticeable quite early, namely, as I have shown you in the first history, by a marked irritability and agitation of the children. And this also in our series was seen in most of the children, often together with that are symptoms and signs at onset. That is important to keep in mind. Often it was combined already with abnormal movement patterns and general developmental regression, which starts really very early in Krabbe's disease. Whereas in the later onset form, it was in all the cases, and that is very much in accordance with all which is published in the literature. Whenever a child beyond the age of 1 year starts with Krabbe's disease, or an adolescent or an adult, it is an abnormal movement, an abnormal gait. And this is important for you to recognize, in contrast to other diseases, such as, for instance, metachromatic leukodystrophy or vanishing white matter, where later onset cases often start with cognitive abnormalities before they present neurological signs. And how does that look like in more detail? These are our data on the early infantile. That means the children starting before 6 months of age. And you see here, the orange is the onset. They are put in the graph here according to their onset. So onset is really very early in many children, but most of them start at around 3 months of age. And all of the children, even those where the parents mentioned some abnormalities for irritability, mostly very early, had first developmental milestones which they acquired. That means head control, the blue line, and also grasping. But then both head control and grasping was very rapidly lost. And you see that in a very narrow curves. So you see that there is a normal development and then a rapid decline of competencies. And in those whom we had data on late data, we saw a death which was quite early in all the children before, or on most children before the second birthday. So that is the second message. Early milestones are achieved, even in the early infantile children, in all of them, in our series at least, but then they are quickly lost. And death is early. And here are additional data on loss of fixation and tube feeding. And this is also something which comes early. Loss of fixation is usually before they get 6 months old, and gastric tube feeding around the same. So again, take home message, early signs are also loss of fixation, and very early comes already need for a gastric tube. And now I'm going into the typical MR. I'm always trying to show you first the clinical signs in their history, their natural history, and then the imaging part. And as I've shown you already, the typical abnormalities of the cerebellum, the dentate nucleus, and mostly often, very often accompanied by white matter changes of the cerebellar white matter. On the sagittal slide, you can see it also very nicely, which is accompanied by central white matter abnormalities. And they are really concentrating in the central area, which is affecting the pyramidal tract. And then these changes or these abnormalities in MR change very quickly and show a quick worsening. And what is very typical in children with early Krabbe is this cystic degeneration. It is really a cyst because this is like CSF and ISO intensity. The pyramidal tract gets into a real cystic degeneration, and which is of course accompanied by more major signs of global extensive white matter involvement and global atrophy. And now when you look when we looked at the children who started in the second half of the first year, they showed very similar signs of the white matter in the covering especially the central region and the pyramidal tract, very similar. And I couldn't show it in the first chart, but here the very typical affection of the corpus callosum, which is absolutely typical for Krabbe's disease, is seen, but the cerebellum looks normal at the beginning. And only during follow-up, that's the same child 7 months later, not only there is severe white matter changes now and atrophy, but here also the cerebellar white matter is affected, but not the dentate nucleus. So that's important to know. Dentate nucleus is a sign which is typical for really the early infantile Krabbe's disease. And when you look at the natural history, the follow-up of these children, which we measured with a score which we have developed for the MLD, that is a scoring starting with walking normal gross motor function, walking without support, ending up with no locomotion, no head control anymore. You can see that we have just these data which we can present because the later onset children are much more rare. But what is quite striking is that there are children with a quite rapid regression, and that is, here you can understand it because this child started in the second year or early third year of life, but here this is a child at the age of 5 years, which also had a very rapid regression, and the child which had a much earlier onset had a quite slow regression. So our impression, and that is a bit difficult to verify with what is published, but you can summarize that disease course in later onset is quite variable. It may even be very rapid, but it seems not to be related to onset, because in other diseases you have the impression, for instance, in MLD, the earlier they start, the more rapid they progress. This is not exactly what you can see, with some exceptions also even in MLD, but this is not what you can see here in the later onset Krabbe disease. And to show you the difference between the infantile onset and the later onset, which is quite, despite this conception that you may have a very rapid progression in some cases, as I have shown you, in principle, there is a big difference between infantile onset and later onset. And here are data from our American colleagues from Pittsburgh, Bascu et al., sorry, who put together in a group children with an onset between 6 months and 12 months. These are the red children in the red points here, and children with an onset between 12 months and 3 years. And the majority was the earlier onset, and there is a big difference between very little progress or no progress in all domains: gross motor, fine motor, you can read it yourself, receptive fluency, expressive fluency, cognition, in contrast to the later onset. And in the later onset, the gross motor function was more affected than all the rest of the functions. And this is not one child. I'm sorry, it's very difficult in this situation to bring this is not one child here. These are different children. That explains why they are in different positions with respect to the normal history. And when you then look at the MRI of these children, and I have shown you one already at the beginning, what is absolutely, you really have to look at your images with some apprehension, so to speak. What is absolutely a characteristic is this parieto-occipital or peritrigonal white matter affection, which is together with the corpus callosum pathognomonic, I would say, for Krabbe's disease. And when you go a bit higher up, you can also see this parieto-occipital preponderance or parietal preponderance of white matter changes here, also in the sagittal image, and especially centering on the or also affecting the central part, which explains the affection of the pyramidal tract. And here in the sagittal image, you can also see how clearly the corpus callosum is affected. We saw this pattern also in one late infantile, in an adolescent patient. In here, there was already something coming up, which is typical for the later onset, which is the highlighting of the pyramidal tract. I'm going to show you that in images from a paper, Debs and colleagues. And here is a child with 4 years in comparison to a child with 12 years. So you see that this pattern is really going into later ages also. Typical combination, peritrigonal, corpus callosum, central parietal white matter, central pyramidal tract affected. And the older you get, the more the pyramidal tract is, so to speak, in the concentration of the first abnormalities. That's especially when you look at adult patients, they may have only the pyramidal tract affected, as you can see here. But this is not, I found one interesting case description of a child starting at 4 years and imaged at 4.5 years, who also had just this very isolated pyramidal tract affection. This is really something which is absolutely typical for later onset Krabbe's disease. You want to know what is the difference between ILD and Krabbe? You'll see in the questions. I can show you, and the big difference is there is in the Krabbe there is no contrast enhancement, which is absolutely pathognomonic. In the XILD, you have to do contrast enhancement. And when you look at their disease cause, we had not so many with a later onset, but what we can say is that they have a slow course, and that the patients who started very late at 60 years was a bit quicker than one adolescent where we had a 10-year follow-up. So again, disease course is variable, but it seems to be clearly more protected than in earlier onset. And now we have our first questions.
Okay, here it is, and you have several right answers, actually 3 that you can choose. Okay, now 50% of our audience has already voted. I will leave the question open another 15 seconds and we'll show the results. Okay, so here are the results.
Yeah, so right was 2, 3, and 4. And this, you were not absolutely sure whether these, and I put these questions before my summary of the clinical science. It is not nice of my part, but I wanted to stimulate you to already think a bit about how to summarize. And I think we can close that now. I don't know why this doesn't work. This is what I would like to give you as a key messages about the clinical characteristics in infantile Krabbe. Irritability, spasticity, and also polyneuropathy are first signs. Very rapidly there comes visual loss and tube feeding, and then also cognitive decline. And the cause is really rapid and homogeneous. I tried to show that with these curves, which were very close together. And for the later onset forms, and it is a bit arbitrary whether you take 1 year to 8 years or 1 year to 15 years, or where you make the cut point. The most important thing for you to know is they always start with primary motor signs, and that is what you really, most of you understood, with a gait disorder, and the cause is variable, but clearly less rapid than in infantile Krabbe. Not clearly related to age and onset, but probably the later you start, the more protected. And cognitive symptoms are later signs. And what they have in common are a development which is normal before onset of first symptoms, according to milestones. There may be some irritability in already seen before, but it is important to identify the children, to really look at their developmental progress. And in all Krabbe, neuropathy is very, very typical. And I'm going to show you the second thing, which is additionally very typical, that is protein increase in CSF, in a moment. But first, yeah, and this is just to show you from the Worldwide Register that what is also suggesting that the later it starts, the more protected the cause is, that are survival curves. So survival is not good, and mortality is starting early, in early infantile, a little later in late infantile, and later onset in adolescent come even later. So that is again describing the different dynamics. And now comes already the second questions, which I try to make you really look at images, and please try to identify the 2 Krabbe children which are in here.
Okay, I think the attendees need a little bit time to look well at the pictures. Now we have 50% that have already voted. Okay, so I will now show the results.
One was really very good. And the next, which is correct, is 4, which is the second most frequent. So that's quite good. I think you can close that, and I'm giving you the I'm giving you the results. These are the two Krabbe. This is the early infantile, and most of you recognize this combination of dentate nucleus and white matter changes in the cerebellum. And this is the later onset Krabbe. And here you can see the difference to X-ILD. This is, I have to admit, is the rarer frontal variant of X-ILD, but you have the same sort of symptoms in the more classical part when it's in the parieto-occipital white matter. It looks a bit more volume taking, and when you do contrast enhancement, there's contrast in the measurement. You have contrast enhancement, which is the big difference between the two. And this is a child at 10 years with no myelin. It's a hypomyelinating disorder, Pelletius-Merzbacher. This is an adult MLD. For those who come from adult neurology, if there are some, which could also be confounded with hereditary diffuse leukoencephalopathy with spheroids. They look very similar. And this is just non-leukodystrophy. This is a PVL, periventricular leukomalacia, so at least no pattern. And to give you a summary also here, again, to remind you, in early, infantile Krabbe, it is the combination of central white matter changes with the cerebellar and changes especially in the infantile form, and in the later onset you have the typical signs of the peritrigonal and corpus callosum. I can only repeat that, and the later it starts, the pyramidal tract is absolutely is the last part which is affected. So, well, no, the first part which is affected and is exclusively affected. I'm talking a bit quicker because I see that we have not so much time anymore. And I wanted to show you some about diagnostic procedures. I go through that quickly. You have to measure beta-galactocerebrosidase. And usually the laboratories do it with an artificial substrate because it's easier and quicker done. But there is a risk for false positive or negative results because of the different chemical properties of artificial substrates. So whenever there is a mismatch between clinical, genetic, and biochemical findings, please look whether the enzyme measurement was done with artificial substrate and repeated with natural substrate. Our laboratory does that with the radioactive labeled, and I'm just showing you. We had, for instance, 3 children, colleagues sent to us because they were not happy that they had normal GALC and activities, and in fact they were not normal. They were clearly very much abnormal. And this is the other way around. Colleagues sent us samples from patients where they were doubtful that they had Krabbe's disease, which was given to them according to the GALC activity, and in fact they had a normal activity. So please think about that. And I just have to tell you that GALC activity measured in leukocytes or in plasma is not correlated with onset of the disease. That is in contrast to, for instance, metachromatic leukodystrophy, where there is a correlation. And this is also others who found that. And the second important thing, of course, is genetics. And you have to look at the GALC gene, deletions and mutations. And the most frequent is a deletion, which is found in 45 of the mutated alleles. And there are also mutations which are typical for later onset, and homozygosity for this deletion, I have to say, is typical for is predicting infantile onset. But prediction is difficult because you have not very often a homozygosity, but you may have compound heterozygosity, and then you cannot predict anymore the disease course. And other variants are not clearly related to cause. So altogether, there is little genotype-phenotype correlation. But there is some correlation with CSF protein. Our colleagues from Heidelberg had looked at published data and found that there was clearly higher CSF protein in the early infantile versus the late infantile, the juvenile, and the adult. So maybe that was a bit quick and a bit not very nice to ask you now already questions, but please try to look at these.
Here again, there are three options that are correct. Okay, 15 seconds to go. And here are the results.
This is very good. So it was so quick that you had it very quickly. This is right. And this is right. And this is also right. Oh, that is our recommendation, at least. Very good. So now we have not much time left, I'm sorry to say, for the complicated discussion of treatment options. But I try to be, again, try to be concise and short. Stem cell transplantation was an option which came into discussion, especially after the extraordinary study of Maria Escola and her group, published in 2005, where they did transplantation very early of these children in a pre-symptomatic or symptomatic stage. So that means very early in newborns with a family positive family history, but they were pre-symptomatic in comparison to some symptomatic children. And what you can see clearly from the survival curve already, that the approach is clearly nothing for the symptomatic children because they are very close to the untreated cohort, whereas the pre-symptomatic children survived very well. And then when you looked at the outcome of these children with respect to their development, again, the symptomatic children, the black ones, they did not profit at all from the transplantation. But the pre-symptomatic were much better than the asymptomatic, the symptomatic children with respect to all these domains which you can see in these curves. But one has to say that they were not really according to the normal development, but they may even have a late deterioration of development. The development was not absolutely normal, but it was much better than in any untreated child. And that's why in US the newborn screening started, and the overall result of this newborn screening, however, was that there were not many children identified which could be clearly related to an infantile onset, and quite some of these children died. Here in a series of a combination of newborn screening identified children with family history identified children, 5 out of 18 died. And only one of them had a normal cognitive function, and but the others were at least having some quite well development. And in the that is the feedback from the first phase after the neonatal screening, where also a high mortality in the only identified newborn screening group was reported. So that's why neonatal screening was then stopped, but is still going on in some parts, but not in Europe. I don't know of any country which does neonatal screening in Krabbe. When now you look at the date of transplantation in late infantile and later onset Krabbe children. So these are children with onset before 12 months, but after 6 months late infantile, in comparison to children with onset above 12 months, you can clearly see that the later onset forms are better in follow-up than the early onset forms. But best are the children which were asymptomatic, that pre-symptomatic at transplantation. But the big challenge is how to identify them and how to predict the disease course. I have shown you that neither enzyme measurements nor mostly genetics is a reliable predictor, and other biomarkers have to be taken into account, which is still a discussion ongoing. And the last slide to show you is what is going on in gene therapy. There are 2 trials going on, one worldwide. We have in Europe 2 centers, Amsterdam and Manchester, from Passage Bio, where they do a single application intracisternal dose in children starting before the age of 6 months. That means early infantile Krabbe. Children are included between 1 month and 9 months of age. Up to now, only 1 patient is included. And the second study is only running in the United States, a combination of transplantation and gene therapy. Children who have a reasonable neurological function after transplantation, again, infantile children are receiving a dose of intravenous gene transfer of the AAV10 vector. So this is just to inform you about this, and this is now to summarize, to have a little bit time for discussions still, I hope. I try to show you, and I really try to put my emphasis on that, because important is to know about the clinical characteristics and R patterns of the children with Krabbe, to be able to it is such a rare disease, and you have to be very attentive to identify children which are developing this disease. And I try to show you that Krabbe is the most frequently starting very early, but later onset forms are those who are even more important to identify, because they have treatment options which are realistic even when they are already starting to have first symptoms, as I try to show you at the end. Stem cell transplantation is only makes only sense in a pre-symptomatic infantile child, but it can make some sense in early symptomatic later onset forms. And enzyme measurements you are a bit, or you have to know that there are pitfalls when using artificial substrate. And what you have to know about genotype is there is not much correlation between phenotype and genotype. So this is my conclusion, and I hope that we have some discussion now. Sanja, are we opening the discussion, or?
Yes, thank you, Inge, again for this great and very interesting talk and the summary of all the results you have on Krabbe. So yes, we are now accepting questions. If you have some, you can write them in the Q&A box. Yes, and there is the first one. Can early onset Krabbe has thickened optic nerve on MRI?
It is not mostly the thickening. It is more the contrast enhancement of nerve roots, which is typical for early onset Krabbe.
Thank you. Then another one, what about treatment options or studies on efficacy of treatment of adult patients with Krabbe?
That is a very tricky question, because it is very difficult to judge on the effect of such a treatment, because you know so little about the natural history. And from making the parallel with the later onset observations and the little which is published, you could argue that in an early onset, as long as there is only motor signs and as long as the MR is still quite is not so very severely affected, you could discuss with the patients that there is this option, and you could recommend that. But you have to also admit that there is not much data about it, and of course it carries a lot of risk also. So usually one has time, and usually one can or one has the time to look for a good matched situation for a donor, because in such a situation where you have a very experimental approach for treatment, you have to care very heavily that side effects are minimized as most as you can.
Thank you. Another one, could you recommend galactose-sphingosine as biomarker for the diagnosis?
Yes, that is one of the biomarkers which are extensively studied now. The question is always, when does it start to be abnormal? Psychosine, for instance, is a measure rather of disease activity than it is not characterizing the presence or absence of disease, but the disease activity.
Thank you. And another one from Xenia. Do we know anything about the factors that lead to earlier versus later disease onset in some patients?
That is a very difficult question. You could argue that because what we know is that homozygosity for this deletion causes is very highly related to early infantile cause. So that must have an effect. But the modifying factors, because there is otherwise very little genotype-phenotype correlation, and frustratingly, there is also little correlation between enzyme activity, but mainly in the leukocytes. When you look in tissue, in fibroblasts, you already have some correlation, and one of the hypotheses could be that in nervous tissue, the activity is a bit changing, or it must clearly be higher in those who have a later onset than in those who have an earlier onset. But the reason for that, I don't have an answer.
Thank you. So at the moment, there are no further questions. I think I can already announce the next webinar, which is taking place next week on the same day, Tuesday at the same time, and it's about DBS in dystonia. And if you have no further questions, I thank you, everybody. Thank you, Inge. Thank you for all the questions and interest of the audience to this topic. And I wish you all a nice afternoon, and until the next time. Thank you.
I would also like to. It is a bit a pity that we can not hear the questions, and we cannot see the one who asked questions. But I would like to thank you for following the presentation, and for giving questions, and for also answering these a bit provocative imaging questions. I discussed with Tanya whether we should do it or not, but I thought you all have or you should have the approach to look at images, and that's why I thought you should get images also to touch on. Thank you for that.
Great. And then there is another thanks from an attendee, from Nana. Thanks for so interesting presentations, she says. Yes, and of course, I can always give you a speak permission, so everybody, you can know this also for next webinars. If you like to speak up and ask your question live, I can give you a speak permission, and you can go live into our webinar, so to say. Okay, great. Thank you, everybody, and have a nice afternoon and evening. Bye-bye.